Greetings. So in this lecture, we're going to talk about osteoarthritis. So remember we started with rheumatology, right? Study of joints. Um, and we talked about how symptoms may be inflammatory or non-inflammatory. So a patient comes in and says they have pain in the joint, but you don't actually see inflammation. Then they don't have arthritis, they have arthralgia. And the goal is to figure out the arthropathy, which is what the pathology or disease is. So again, if it's joint pain or arthralgia, that's the big concern, and there's no arthritis that we see, well, guess what? Uh, Now you have osteoarthritis. And that's one of the very likely diagnoses. Let's take a look at a picture of a hand. And I've gotten this from Unsplash, the website. That's the source. So when you look at hands, these are our distal joints. They're called DIPs. Okay. And after the DIPs are distal phalanx. And again, it's the thumb one is thumb DIPs right here. Then you have proximal PIPs, joints that come after that. As you notice, the thumb doesn't have a PIP joint, okay? But it does that. So there's a middle phalanx that comes after the PIP, okay? And then there's a proximal phalanx uh, bone, and again you have MCP, okay? And that's the metacarpal phalangeal joints right here. Okay. And then for the thumb, this is the MCP right here. So when we talked about rheumatoid arthritis, these joints are spared. Rest, all of the other joints are involved. But if you have inflammation of one of these joints, the DIPs, you can pretty much rule out rheumatoid arthritis. Okay. And then you have metacarpal bones that are right here. And then you have carpals. Okay. And then you have the radius, which is again on the thumb side where your radial artery is. And then you have your ulna that gets connected to the carpals. That's the wrist bones. Okay. So again, understanding this, now you know rheumatoid arthritis in this area. Okay. But if there's DIP involvement, then we start to think more towards osteoarthritis. So let's take a look. Osteoarthritis is not symmetrical, it's asymmetric. However, the biggest thing that separates osteoarthritis is it is a non-inflammatory. Again, it's chronic, okay? And unlike poly, it's more oligo. It's a couple of joints. Osteoarthritis is a bad name because it's got the word arthritis in there, which seems to suggest this is inflammatory, because that's what arthritis is. That's why I don't like this term. I would rather we use something like degenerative joint disease, because that's what that is for the most part, there's biomechanical wear and tear. Now it can be accelerated if I have things like gout, or I have pathologies of my joints such as rheumatoid arthritis. But the inherent nature of the joint is, and its wear and tear, uh, that inherent nature leads to degenerative joint disease. So not inflammatory or not arthritis. Would you have systemic constitutional inflammatory symptoms such as fever? No, you wouldn't. What about ESR and CRP if you get that drawn? It's going to be normal. What about if you aspirate the joint fluid? What are you going to see? Nothing. It's going to be normal. not septic and not inflammatory. Okay, so it affects the joints more often than not that do a lot of work. So weight bearing, repetitive movement like DIPs, hip, knee, ankles. What about the first joint of the thumb that gets used a whole lot? Okay, writing, mouse. Okay, again, there's a couple of findings. It's called Herbinden's nodes and Bouchard's node. Herbinden has D in it. These are nodes you find here in the distal DIPs. Okay, and Bouchard's nodes are in PIP. Okay, right here. Okay, which is a stark contrast to Swan's neck and Boutonniere's deformity. Pain is worse in the evening after we've used the joint. Not AM stiffness is not greater than 1 hour. AM stiffness is less than 30 minutes. Okay, that's how we separate the inflammatory, and the issue more is in the evenings the pain is worse. As I said, ESR-CRP is not elevated. Arthrocentesis is going to be normal. It's going to be elderly patient whose whose joints have seen some mileage. Okay, the more the mileage, the more the wear and tear, the higher incidence of degenerative joint disease. What happens? So remember the cartilage that we have that cushions the two areas where the bones come together? Well, you got lost or damaged cartilage. Okay, so as this cartilage gets damaged, the joint space narrows and the bone starts to rub against each other. And then there's thickening of the bone, which is thickened subchondral sclerosis. And then the bone starts to develop these growths. Remember in rheumatoid arthritis it was erosive. Here the bone tends to grow because of the rubbing of the bone on each other. Okay? So that's what happens. That's what it does to the bones in the joint. How do you treat it? So this is a good decision tree. First, is there a secondary disease that's accelerating degenerative joint disease? If yes, can we treat it? And if we can, yes, let's do it. So if it's inflammatory joint disease like gout, let's change that. Let's treat it. Mechanical issues, if they're joint or muscle or bone pathology, let's treat it. If there's trauma, we really can't treat the past trauma. We can just treat it at the time the trauma happened. And things like acromegaly. So these are things that accelerate the wear and tear in the bone. The goal is if we can treat it, let's do it. Because that means it's going to slow down the progression to the joints that are now degenerated and are not working. So that's one. Second step, is there something I can do to stop it from getting worse? And so there's things that are non-modifiable. I can't do anything about age and genetics. It is what it is. However, there's some modifiable risk factors. So if I am obese, my joints are going to have more wear and tear because again, they're going to have to carry more weight. Can I lose weight? And then if there's an overuse component, can I use proper body mechanics to manage that? So I rule out secondary diseases that make worsen this and then do things that are going to stop it from getting worse. Okay? Because again, once you lose the cartilage, it's difficult to get it back. So the goal is to stop it from getting worse. So weight loss and proper body mechanics. Last but not the least, how can I maximize function and minimize pain? So non-pharmacological approach to this is exercise. It helps us lose weight, and then also because I move around, um, my body produces natural endorphins, which keep me moving. So exercise is very good. Assistive devices and insoles, physical therapy, occupational therapy, and heat and cold therapy. So those are non-pharmacological approaches to maximizing function and minimizing pain. Pharmacological or medical surgical management starts with topical treatment, such as salicylic acid, capsaicin, Voltaren topical treatment, because it does not get systemically absorbed. And there's a lower systemic absorption, so that means lower symptoms. And it's on area which is actually affected, which is actually the best thing. You want the medication to be in contact with the area which needs it. Once that doesn't work, we actually put the patient on acetaminophen or Tylenol. Why? It's not an NSAID. This is not a non-steroidal anti-inflammatory. This doesn't have an anti-inflammatory component. Okay? And again, look at the pharmacology videos on acetaminophen, and you'll have a better idea if you're not sure about this. But DJD, degenerative joint disease, is non-inflammatory. So it really doesn't need an NSAID as first line. We can try acetaminophen. Okay? Let's say that doesn't work. Then we start them on NSAIDs. Do you see the stepwise? We start the topical, then we look at acetaminophen, and if that doesn't work, the provider may consider starting an NSAID. Okay? Once that doesn't work, then we start to use some big things. This is what I call intense management. And we're actually getting to the last step here. But you consider using opioids. Again, they have symptoms, that they have side effects. So there's addiction, there's several other symptoms, constipation, altered level of consciousness, lots and lots of issues with opioids. But the provider may consider it. Once we get to this state, we are done with the medical management. Now we've got to start to do some more invasive management. So, uh, if there's an effusion that's present, the provider may choose to take out the effusion and aspirate the effusion and inject steroid in the joint. That's corticosteroid in the joint. So that takes out the inflammatory parts, that takes out the gunk, so to speak, and the steroid calms the inflammation down. Okay? Even though there's no inflammation. So what does that mean? Essentially, it just calms things down in the joint, causes the pain to be less. Okay? So remember, pain is symptom that something's going on. So corticosteroids would decrease that pain. Mediators that cause pain, keep them moving. Okay? So again, we take out things that are causing pressure and inducing pain, and we do that by taking out the fluid. And then if we have some mediators that are causing the pain, we give them corticosteroids that decrease that. The provider may choose to give hyaluronic injections in the joint, and they work by several mechanisms. Okay, But by this stage, essentially what they need is surgical replacement of the joint or arthroplasty. Okay, so that's actually the stepwise treatment from a pharmacological perspective. Okay, so nursing interventions, what would you do? Think about it. So they come in with symptoms. The first thing is to get them diagnosed. Okay, what does it sound like? There's no inflammation. It's asymmetrical. It's in the weight-bearing overuse areas. Provider may choose to do x-rays to confirm the diagnosis. And usually that's not done. It's history and physical. Okay. Uh, so they get diagnosed. What next? You know, is there a secondary disease that's causing this degenerative joint disease? If there is, let's get them diagnosed and treated. Okay. Once that's done, how can I stop it from getting worse? Lose weight. And, proper posture, prevent overuse. It's two. And then last but not the least, how can I maximize their function and minimize pain? Exercise, PT, OT, heat and cold therapy. I'm going to use some insoles, some assistive devices like cane so that they can function. And then with meds, topical treatment followed by Tylenol, which is first line, followed by NSAID. And then next steps are tougher because they deal with opioids, potentially, joint aspiration with steroids, and then hyaluronic acid, and last but not the least, joint replacement. Okay, and that's osteoarthritis. Okay, so let's do a quick recap. Okay, osteoarthritis, bad name, it's degenerative joint disease, mechanical wear and tear, and it's the DIPs, hips, knees, ankles, where we have lots of use in weight bearing and repetitive motion that get affected. Herpedines, DIP, and Bouchard nodes. Pain is worse in the evening. AM stiffness less than 30 minutes. You'd have cartilage that goes bye-bye, and because of that you have joint narrowing. When the bones rub on each other, you start to have bone growth, which is osteophytes, and subchondral sclerosis. Treatment. Secondary disease, treat it if you can. Stop it from getting worse. Obesity and overuse. Those are the two areas to address. And then maximize function and manage pain. So start with exercise, assistive devices, PTOT, heat and cold. And when it comes to medical and surgical management, topical treatment, acetaminophen, NSAIDs, opioids, and then last but not the least, you have three things in your arsenal. If there's a fusion, aspirate and inject corticosteroids, hyaluronic injections, and then last but not the least, a surgical replacement. That is osteoarthritis.